I'm talking about lung function in preterm infants, and what is important is to bring home to us neonatal and pediatric crowd that it's actually a recognized aim for the roadmap of big societies like the European Respiratory Society to include preterm lung health in the top priorities of the running decade. So apart from preventing air pollution, prematurity, low birth weight associated lung disease is one of the big targets, not within our own community, but larger communities as well. Which brings me to the general question, what's our life expectancy for lung function, which is the topic of my talk today. And if you take your 1 minute, 1 second capacity, where 100% would be normal, and your progression over your lifespan, 90 years hopefully, and much more for some, a healthy individual, even at the age of 60, 70 or 80, would still operate on at least half of his or her optimal lung function. And because nature is kind to us, has given us far more lung capacity than we usually need, we hopefully stroll through life quite happily. As you're well aware, this looks slightly different for the smokers, and that's why obviously we don't want to smoke. But what we do not know is the effect of neonatal lung disease. So as you can appreciate, about the peak of our lung function would be at around 20 years of age, which is great. And then because we don't oversee as many preterm infants older than 40 years of age, we don't really know how neonates fare. But what we do know, and I'm going to show you some data, is probably the peak isn't quite at 100%, and the progression of lung disease or lung health is slightly different too. So if we talk about lung function in preterm infants and the progression to pediatric life and then adult life, we can assume that there's a concept of tracking. How do we know this and how do we define tracking? Well, a great study done in Tucson, Arizona in the United States looked at a birth cohort of infants, did lung function tests on all the infants born and who contributed, so 160 infants in the city in that year contributed, preterm infants and term infants, and they looked at different ways of testing them. This is an asleep infant with a face mask and a flow sensor, a pneumatic mat which you can sort of synchronize with the expiration of the sleeping baby. And when the baby expires, you give a good old whack of compressed air, and the baby has a forced expiration. The video didn't work this morning, so I can only show you this image. And of course, when you're a little bit older in life, that's what we do at our GPs. We blow into our mouthpiece and we get this 1 second maximum expiratory test. So when we compare preterm infants and term-born infants with regards to their performance during these tests, what we can see is that at different time points in life, there is the preterm and the term population, and they seem to be working in synchrony, but they don't quite work in the same way. And the preterm infants born have a persistently lower 1 second expiratory breath than the term-born infants, and that equates to the concept of tracking. So born prematurely with poor lung function means your lung function is not optimal at term, as term infants at any given time in life. And this is a different study from a different population of infants, and again comparing two cohorts of extremely low birth weight infants born in the 1980s and 1990s, so appreciably at different eras of preterm management. They compared non-BPD babies with mild, moderate or severe BPD babies, and as you can see, the preterm infant babies with BPD had consistently lower lung function values than those with no BPD, or the healthy controls, both in their teenage years and in adult life. And just to bring the same message home, another study from Switzerland, Traxel and colleague, again looking at different time cohorts in a small number of individuals, showed that if you were tested at different time points in your life, either at 15 years or at 18 years, I think the battery is just dead, there's persistently lower lung capacities for those affected with neonatal lung disease. So which factors play into this? And let's look at the risk factors for having neonatal lung disease, which may develop into bronchopulmonary dysplasia. Highlighting here in the bold script is that what probably affects us at the moment, us neonatologists, us here in the room thinking about surf-on and whether we should contribute or not. There's obviously genetic susceptibility, which we continue to learn about. Low gestational age and low birth weight, right up here as well. Interventions which are associated with neonatal lung disease, either ventilation, respiratory support causing volutrauma, barotrauma, prolonged mechanical ventilation, and the toxic effect of higher oxygen concentrations may all well have a role to play in suffering and accelerating newborn lung disease. Things that we cannot always influence so well, like nutritional factors of the fetus, and of course sepsis and chorioamnionitis have a big part to play as well. Thank you, Njani. Excellent. Thank you. I was given this picture by one of the families in Germany which we cared for at the Charité, where I did my training, and it obviously shows a near to 1-year-old infant who suffers from severe bronchopulmonary dysplasia. He is still on CPAP, he plays with his rattle, but obviously the CPAP device will hinder him for having a completely normal neurological development. It says here, "Be kind to me, I will pay into your pension fund," which is an optimistic statement. Parents gave me this picture to say, to use it in my talks, to say, please do everything you can to prevent chronic lung disease and for other babies to suffer like we do, because father has moved out of the bedroom, mom had a baby with her, the marriage broke apart, and they didn't have a very happy family life in the end. What are the consequences? Of course, recurrent admission, oxygen dependency as this guy, more susceptible to viral illnesses as we well know, and poorer lung function, etc., etc. Sadly also poor neurological outcome. Well, that's one part of the coin. I want to introduce another baby here, which is a guy called Falki, who is born at the very other end of the spectrum than the surf-on babies, but he's obviously born at 23 weeks. He was an extremely high-risk baby for chronic lung disease, and he stayed with us for quite a while at the Charité. To make matters worse, both of his parents were lawyers. He's a male twin, no complete antenatal steroids. Parents are absolutely lovely people, but for the many, many weeks that they were with us, they were trying to stop treatment. They were trying to do everything they can to avoid having a child dependent on continuous care. Needless to say that he was intubated and ventilated for quite some time, and he had surfactant, but that's not the point. The point is his lung function. Volpi et al. Brought out a risk stratification, thingy where you can put in your neonatal 3-letter diseases and come up with a estimation of poor neurological outcome. So I modified this by just popping in Falki's disease spectrum to see how he would fare on a pulmonary, if we transfer this into pulmonary life, how he would transfer. And his odds ratio for poor pulmonary outcome are similar to those for poor neurological outcome, because he had bronchopulmonary dysplasia after quite some time. He was a male twin with incomplete antenatal corticosteroids. He had brain disease, etc. So he was a high-risk factor candidate for poor pulmonary outcome. How would he fare in general terms? lung function testing of infants less than 1 year of life is quite complex, and as you saw with the pneumatic jacket, cumbersome and requires a lot of compliance both on the parent side and on the baby side. Monica Gapper and Janet Stocks in London have investigated cohorts of preterm infants and looked at their lung function. If you take the mean here for normal lung function at any given stage in the first 12 to 14 months of life, and Z-scores as a deviation of the mean, you can see that the preterm infants started off lower than the ideal mean, and they ended up after 12 to 14 months more than around 2 standard deviations of the mean. So significantly lower lung function of the extremely preterm infants in the first year of life. And this is the same group, this time by Roehr et al., but from Janet Stock's lab, just shows that if you were poor in the first instance, you were very, very likely to have poor lung function even later at around 70 months of life. The group that I trained with in Berlin did tried to replicate these results from Roehr et al. Over a longer period of time. We looked at about 60 infants, some of which with BPD, some of which without BPD, and we tried to look at their lung function over this couple of years in life, the first couple of years in life. You can see that the mean gestational age was 26 weeks, 28 weeks up to, and some of them were 24 weeks. Gestational age and birth weights at around 800 grams. We did pulmonary function test at 50 months, 70 and 100 weeks of post-menstrual age, and we found similar results than the ones before, but a little bit more encouraging, because after 50 weeks of age, we found that actually the concept of tracking was persisting, but encouragingly, there was a parallel lung growth and an improvement in all lung function parameters, here shown as the maximum volume expired at 1 second in liters per minute, which goes on for the babies with BPD and those without BPD. And the minute ventilation values actually also, with a lot of overlap in the confidence intervals, didn't seem to be much worse either. So that was actually taken as a positive in terms of lung development over time. So going back to our little baby Falky here, so his first year pulmonary development would not be great, obviously, and it would sadly be way below the mean of a term-born infant to be expected. We know that by being born prematurely, no matter what gestational age, these are all pooled data, means that you have a delay in your lung function, and luckily, if you got adequate nutrition, your lung function may be going parallel to your somatic growth, which largely should be good news and hopefully not too much bad news. Looking at the data beyond the first 100 weeks in life, I go back to the first description of bronchopulmonary dysplasia. You can appreciate that this 32-week or something baby suffers from severe respiratory distress with recessions of his thoracic tug and his intercostal spaces. He's got a very crude cannula stuck in his little neck, poor little guy, and he's definitely crying for help. And these are the babies that Northway et al. Treated with mechanical ventilation. This is a biopsy of the lung tissue showing all these eosinophils as sign of pulmonary inflammation. Vasculature here, airway here, and you can appreciate that a lung that is full of eosinophils and full of inflammation is very uncompliant, doesn't breathe well, and needs, for instance, surfactant and a lot of other refined treatment to heal. Northway took the pains of following his cohort from the 70s into the late 90s, and he did lung function testing on his cohort at 18 years. He didn't have too many of them, but as you can see, they were born in the 60s and 70s, so congratulations to him for persisting with these tests. And he found that only a quarter of his survivors in those days had no symptoms, airway symptoms, and 75% had significant to to reversible airway obstruction. So this is the first larger longitudinal study in lung function of preterm infants, and it does confirm that whilst some of our babies may be free from long-term consequences, it's a more than 2/3 chance that when you're born preterm, you have some effect on your lung function. The UK is the home of the EPICURE study, and the EPICURE studies are usually quite well known. We looked at a whole birth cohort of 20 of extremely preterm infants born in the year 1995, and also in the Republic of Ireland, of those extremely low gestational age infants. Looked at more than or around 700 infants. There was an ongoing effort to assess babies at school age, and there was some attrition. 225 were seen at school, and compared to term-born infants, and around 50 were seen later in life, and assessed to greater pulmonary function testing. Of those 50 who were extremely low gestational age infants with low birth weight, 70% were given the diagnosis of bronchopulmonary dysplasia. Over the couple of assessed at school age, they had wheeze in 50% of cases and carried the diagnosis of asthma in 55%. Only 18% were regularly treated with beta agonists for asthma, and 10% were on steroids. Looking at the lung function test of this small cohort within the EPICURE study, airway obstruction, inhomogeneity, and gas trapping was found in almost 80% of these infants. And you can see on your left, the EPD preterm infant fared worse in terms of deviation from the standard. In the FEV1 Z-scores, they were worse than the preterm infants who did not carry the diagnosis of bronchopulmonary dysplasia, and they were significantly worse than the term-born infants, which they used as controls. So for the 1 year and beyond period of life of a preterm infant, we can conclude that, taking Falky as an example, there will be significant reduced lung function even later in life. And having a history of bronchopulmonary dysplasia makes it more likely for you to have a worse lung function than any other newborn infant. I talked lots about Falky, and I want to show you a picture of him at 5 years. He was doing surprisingly well for all of us, and to give credit to his parents, they were absolutely madly in love with him and doing everything possible that they can. And I'm in regular contact with his family. I can tell you he goes to a normal school, he speaks 3 languages, and he's a little bit clumsy, but he enjoys activity. But when I got this picture, I got the picture together with a letter in German, of course, so don't worry about reading it. Basically, she said he's doing great, but he's not too fond of sport. He doesn't really like the activities. It seems like he's easily fatigued. So the question behind all this is, he's got reduced exercise capacity, and will this go on? That was sort of the general gist of the letter that parents wrote to me. So what evidence have we got to give the parents something to look forward to, or some hope? There's a study from Sanish Katisha's group in Cardiff, who's a very avid researcher in pulmonary lung function of newborn infants, and they looked at 8 to 12-year-old EPD survivors, published a couple of years back. So babies were born just around the turn of the century, and they looked whether they would actually respond well to bronchodilators, because as you saw earlier in the EPICURE data, not many preterm infants are actually given or were regularly treated with bronchodilators for very many good reasons, which I'm happy to discuss later. So Katisha and colleagues wanted to see what, in the face of common claims about exercise intolerance, whether bronchodilators would help. They had 62 preterm infants and half the number of healthy term controls. 40 or near to 50% of the preterm infants had a diagnosis of chronic lung disease. They found that amongst the preterm infants here in blue, the ones with chronic lung disease here in red, there was a significantly higher diagnosis of asthma, 30% in all of them, compared to 40% in the term-born infants at 8 to 12 years of age, I remind you. Current complaints about asthma were quite high in both the preterm infants with or without chronic lung disease compared to none of the controls. Exercise-induced wheeze was quite common in 20% of cases, you could say. Parental smoking, very sadly, was much, much higher, significantly more higher in the preterm infant group than in the term-born infant group. And we know that parental smoking is by itself a risk factor for reactive airway disease. And interestingly, the activity hours per week were similar in both groups, but you can see that those classified with chronic lung disease had an hour less exercise per week, so either reflection of their exercise, the lack of exercise capacity, or other things. This graph very crudely shows the 1 second expiration maximum at 3 time points, one before administration of a standard dose of bronchodilator. Then those guys were put on the treadmill and on the bicycle and were exercised. And after the exercise, they immediately had another 1 second breath test. Again, they were very compliant, 8 to 12-year-old children. And then they were given a bronchodilator. And this is sort of showing you the effect after the bronchodilators a couple of minutes later, and shows that in the term, the term healthy infants, the preterm and the preterm babies, the same effect of bronchodilator was present. So although this is an experimental study where it's just the effect of bronchodilator after exercise and not a large randomized controlled trial where you look at bronchodilator use over time, this indicates that these days, even particularly in the BPD-born infants, some effect for bronchodilators. So Falke himself, again, was diagnosed with the label of asthma, and his pediatrician did not, for his preterm lung disease, wasn't sure whether bronchodilators would work. Discussing the results of the current study with him, we suggested that they would do proper lung function testing on him, and then, in case he did react, an individual trial of bronchodilator may be indicated. So let's go away from these very detailed tests of our lung function testing. Let's look into how we as professionals, neonatologists and pediatricians, have fared over time and whether this showed any palpable effect on our children's lung function over time. And again, Sarah and Salish Katisha from Cardiff did a very wonderful overview where they looked at the studies available for infant lung function testing, most of which I showed you today, over time, starting in the 60s and 70s with Northway and others, and then at the height of infant lung function testing in the 80s and 90s, till the end of the 90s, they found different sets of data. Population size investigated is sort of denoted by the magnitude of the ring, and you can see that over time, the green ones here are all the term healthy infants control in these lung function studies. The mean didn't change, because that would be fast evolution, I would think. However, the lung function data of the BPD survivors, here highlighted in red, did quite significantly change. From having a terrible prediction here in the 70s, 60s, 70s, and 80s to progressing very close to the mean over at least the 90s, etc. And I'm very excited to see what will happen with the babies born 10 years after or babies born today. And obviously SURFON will contribute to giving us more information on what to do with the nearer term infants and how to optimize their lung function over time. So to go back to the initial slide, we know the past experience have shown that we have not managed to give our preterm patients 100% of their vital capacity in FEV1 at the peak of their development, but we hope to improve here, and we hope that for future generations of preterm infant born, their line here will almost 100% simulate the line of the healthy born infant. So I'll conclude by saying that yes, we know preterm birth as such is a risk factor for a high predictor for abnormal lung function in infancy, in childhood, and in adulthood. We know that the effect of surfactant there's a short-term effect and some long-term effect, but we're not very sure about the low preterm infants. So far it's one of the first studies that offers to study the effect of surfactant, the immediate effect of surfactant course in this age group in a large enough cohort to inform us. And for the whole population of preterm infants, although largely now not a hotspot of pulmonary research in pediatrics, for the population of preterm infants, I think we still should, for populations, do lung function testing, and for individuals with symptoms, we surely should do targeted lung function testing. I'd like to end my talk with Falky's latest picture from his 12th birthday, only this last December, and he's turned out quite well, and I hope that we, as a professional group, can help many more families to have happy babies like him. Thank you very much. Quite fast with my talk, so we have no time to discuss it. Any questions?